Well, it's Wednesday, January the 12th. I'm Dr. Steve Stein, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Doll Simons Family Studio. Thanks for joining us on Facebook and YouTube. Pressure continues to build at every hospital in the metro and across the state from the current COVID surge. We can add ventilators to the list of shortages that includes staffing and monoclonal antibodies. One thing there's no shortage of, COVID. All this, along with growing stressors on emergency departments and emergency services. Last Wednesday, we brought together 18 chief medical officers in a news conference to spell out how dire things were across the state from the COVID surge. Several of those CMOs are back with us today to help describe worsening condition, what it means for patients, and what we need the community to do. Also joining us in the studio is Dr. Catherine Satterwhite, Region 7 Health Administrator for Health and Human Services. She'll give us a national perspective on our surge in the Midwest and how she's closely following cities like New York and Atlanta to see what may be coming our way. Her husband is Dr. Louis Satterwhite, a critical care physician here at the hospital. He's our medical director of the medical ICU, and he's in contact with ICUs across the metro and will update us on the extremely serious conditions there. We will hear from this panel and then open it up for reporter questions, followed by community questions. Jessica is watching for those now. Viewers can start sending them onto YouTube, Facebook, and the Medical News Network. You'll find open links to those right here on your screen. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, will join us shortly with a look at this morning's COVID patient numbers, and we'll get numbers from all the CMOs as well. So, let's get to our Chief Medical Officer joining us today. I'm going to start with Dr. Kim Megow, Chief Medical Officer at HCA Midwest. Dr. Megow, how are things?
Good morning, Dr. Seitz. Thank you for having me this morning. I would start by saying the COVID blizzard continues in Kansas City and the metro area. This morning, we have 280 COVID positive patients. That includes 25 in our rural facilities, so 255 in the metro. And of those, 51 are in the ICU, so still a substantial number, and 26 of those are on ventilators, which has been a proportion that's held steady for the last week or so. About half of our ICU patients are on ventilators. We are currently holding 46 patients in our emergency rooms this morning. We only have 2 ICU beds across the entire metro available this morning, and only 4 med-surg tele beds in the metro. So very, very tight bed situation this morning. We are closed to all transfers, and we monitor that probably hourly and come back off of transfer as soon as we have availability and capacity to take care of patients that have requested to move in to the metro. 24% of our inpatients right now are COVID. We have had to move some ventilators around, but we have not run out of ventilators at this point. But we have had to, and thankfully, because the number of facilities that HCA has in the Kansas City metro area, we've been able to share some supplies like ventilators, so that's been helpful. We are very tight on blood supply, as I know the entire community is. We've had multiple blood drives to try to help boost the volume of blood available to the community, but that continues to be a twice daily number that we're looking at. We've had several traumas and other massive transfusion protocols in the last week or two that have really strained our blood supply even further. We do have a federal DMAT team on site at Research Medical Center, which has been very helpful, and we're extremely thankful to the state of Missouri and to the federal government for helping provide that team. I will say that we had hoped we would be able to open up additional beds with that team arriving, but unfortunately, because of the number of employee call-outs, really they've just substituted for our employees who've had to call out because of COVID or other illness. So as of yesterday, we had 432 employees out. I don't have a current number for this morning yet. So that's the status for the HCA hospitals in the Kansas City area.
Sounds like they are stretched, just as I think just about everybody. And we'll hear from Dr. Lisa Hayes, who's the Chief Medical Officer at AdventHealth Shawnee Mission. Lisa, how are things there?
They're not fabulous. I'll start there. Thank you, Dr. Seitz, for the opportunity to be here with you all today. My numbers, I have to report yesterday we had 82 active COVID patients. Just to remind everyone, a week ago Monday, we had 46. So a dramatic increase over this last week and a half. We had 13 that were inactive as of yesterday. This morning, we have 7 in our intensive care unit that are infected, and all 7 of those are ventilated. And we have 8 that have cleared their infection in the ICU, and all 8 of those are ventilated. In our emergency department this morning, we have 25 individuals holding. The longest hold was 48 hours. I can't imagine sitting on a bed in the ER for 48 hours waiting on a hospital bed. We had 12 waiting in the emergency room, and the longest wait was 11 hours. And I looked at the reasons why those individuals were waiting in the ER. They needed to be in the ER, and I can't imagine how unpleasant it would be to have to be waiting for a bed. In the emergency department, we had 6 individuals with COVID that were holding for a bed. Our employee situation isn't any better. We had 107 employees that were positive yesterday. Of those 107, 87 were clinical, meaning that they were having to isolate at home and being away from caring for patients actively. And we had 52 results that were pending. On average, we're typically testing about 40 to 50 employees a day that are having COVID symptoms. You know, our ventilator situation has been a bit tenuous this week. I got an emergency call Saturday night from our chief nursing officer that we were down to 1 ventilator. We came in and assessed the situation. We were able to procure 7 more ventilators, and those started coming in yesterday. As of yesterday, I believe we had 2 ventilators before those extra ventilators came in. You know, the issue with the ventilators is we have many ventilators in-house, but not all of them are able to handle the high oxygen requirements that our COVID patients require and the high pressures that they require to maintain oxygenation and ventilation. You know, the other issue that's a new thing for me is morgue capacity. Had to learn how many bodies our morgue could hold yesterday and determine whether that was going to be adequate for what our needs are. And then as far as monoclonal antibodies, we are running almost out of our sotrovimab, which is the monoclonal antibody that's thought to be effective against the Omicron variant. We're having to basically evaluate day by day what our inventory is. It doesn't appear that we're going to be receiving any new inventory in the coming days. And so we're having to decide how we're going to cut that off and field those phone calls from those desperate obstetricians and community members, community physicians that are desperate to give some relief to their patients with COVID. So that's the situation at AdventHealth Shawnee Mission. And at South Overwhelm Park, very similar. I believe yesterday they had 12 active COVID infections.
All right. Thank you, Lisa. Dr. Raghu Adiga, how are things up at Liberty? Chief Medical Officer there.
Thank you, Dr. Stein, for having me. I wish I could paint a different picture, but it's not here. This morning, we have 60 patients with COVID in the hospital, and 56 of them are active. And if you remember, our highest during December of 2020 was 49 ever. And so every day it's a new record, unfortunately. ICU has 10 patients, and I believe 7 of them are on the ventilator. And we have seen our stream of deaths. Unfortunately, we had 2 more die overnight. I think we are at 11 for this month already from COVID. In terms of supplies, ventilators, we're okay now since we got 5 extra vents loaned to us from the state's strategic stockpile. So that has helped us. And we had to go find more BiPAP machines and high flow oxygen machines just this week. In terms of monoclonals, again, it's the same story. I think we are down to just 2 doses that we are infusing today, and after that, we don't have any. Weeks before, we used to do at least 8 a day, at least 40 a week, and we're going to have to just say, sorry, we have none. And also, the drugs are always in short supply, so are the tests. we had to come up with workarounds about how we can prioritize certain tests done in-house and send some of them to outside labs, which delays the test results. ED is, of course, always full. We've hospital beds are over 100% capacity, and we struggle to staff the overflow area so that we can take the stress off of emergency room. This morning, we had 6 patients in emergency room waiting for beds overnight to be admitted. Our ICU is full. Our first order of business when I get out of here is to see how we can downgrade some patients from ICU, so make some room for traumas that come in or in-house code blues. We don't want to send them to the emergency room to be taken care of. Staff, again, yesterday we had about 38 staff members out on account of illness or other health issues. That really put so much strain. However, we've used every tool that we've had in our surge plan. That includes finding staff from everywhere else. So obviously, postponing non-essential surgeries has given us a few staff which are helping with tasking other nurses elsewhere so they can take more load. People are tired but taking more shifts to work. We have surgeons helping intensivists in putting, doing procedures, and hospitalists helping in making phone calls to the families at home. And yesterday we had business office people in the hospital making beds when the patients are out. So this is all hands on deck time, unfortunately, and this is the situation everywhere in the city right now. This is not a time to slip and fall.
Yeah, definitely not a time to slip and fall. Dr. Samira Antonio Stein in Wichita, how are things there? Chief Medical Officer for Ascension Via Christi Health, I should say. Sorry.
That's all right. Hey, good morning, everybody. Good morning, Dr. Stein. So, I'll give a brief update. We're seeing, unfortunately, a very similar picture, and I like what you just said, Dr. Adiga. We are all hands on deck because we are seeing rising numbers. We have more than 200 patients in our system, and in just the Wichita area. Obviously, we cover also the northern part of the states and south central and the eastern part of the state. So, but in the Wichita area proper, we have more than 170 patients in the hospital. We have about 45 patients in an ICU setting. We've got about 15 patients on a ventilator in total. I did want to mention something about ventilators that came to me. We're thankful that we are right now able to shuffle around ventilators, so we haven't had that be as a shortage for us, which is good. But I wanted to mention that some people have been tracking the number of ventilators used in the pandemic as the only indicator of the severity of the disease. And I do want to say that that's not a great metric to follow. Our use of ventilators has declined because we actively put people on high flow oxygen and other tools, different machines that don't necessarily intubate patients. And those typically don't get an account. I just want, as a caveat to someone who might be looking at the number of ventilators being used as if that's an indicator of how bad is the severity of the pandemic, it's actually not a great measure of that, as a side note. Like everybody else, we're still challenged with seeing staff getting sick despite all the protections they have, all the PPE they can have in the hospital. But a lot of this transmission is happening in the community outside of work. And we're seeing the numbers kind of increase week by numbers that we have not seen. We have, for the first time, actually, crossed a milestone for our system. We now are taking care of in-house of more COVID-19 patients than we have ever done since the beginning of the pandemic. So we have unfortunately beat the 2020 record that we had, or high. And obviously that's putting strain on the system. The EDs are very busy with delays, as everybody has mentioned. And the last thing that I will add is, like everybody else, we're dealing with shortages, monoclonal antibody shortages, as an example that will limit how much we can infuse. But shortages that impact the healthcare system are concerning. These are not new phenomena, but they have accelerated now and during the pandemic and just actually over the last few months. Shout out to the Red Cross. They have been doing a wonderful job trying to supply all the hospitals with needed blood, but we know that they are also dealing with a lot of staffing shortages and people getting ill, and the supply of blood to our communities is lower, which is a reason for concern. And we're also dealing with all kinds of other shortages that are anywhere from drugs to certain kind of IV fluids and things like that. And every day we have teams that are super focused on trying to make sure to deal with those, get those supplies in place. And thankfully, we have been able to find creative ways every day, but it is something that is time consuming to our teams to have to do with that. So that's kind of our picture right now. We, again, are monitoring the situation very closely. And like was mentioned before, it is all hands on deck for our system.
All right, well, thank you. And it sounds like it's difficult all around, Hawkeye, and the numbers are high everywhere, and unfortunately they've continued to go up here at KU.
Yeah, absolutely. Quite unfortunate. 123 active infections today, 25 in the ICU, but a large proportion on the ventilator. 20 of those 25 ICU patients are on the ventilators. 47 patients meet that additional recovered criteria. And then 18 of those 123 active infections are fully vaccinated. We should say, unfortunately, there were 2 deaths over the last 24 hours, and so that is a total of 17 deaths in January alone.
Yeah, this has been a difficult time, and Catherine, unfortunately, as the regional director for HHS, this is the type of information you deal with all the time. Give us a sense about the shortages you're hearing about and what you're seeing around the country.
Sure. So first of all, HHS has worked with states over the last 2 years to build up their stockpiles of backup supplies. So when we're hearing about possible ventilator shortages, Kansas and Missouri both have ventilators available for immediate deployment to those health facilities that may run short of that. We also have things that support high-flow nasal cannulas or other types of equipment that are needed to support COVID-19 patients. The other thing that all of you mentioned, definitely monoclonal antibodies. We know that those are in very short supply. The federal government is deploying all the sotrovimab that we have. So there's none that are held back. They are all going out in weekly allocations, but there still aren't enough for everybody.
Yeah, and I think the question about the sotrovimab is hard because it's a new drug, and so it just takes a while to ramp up the production of new drugs. But ventilators are an old device, so it's good to hear that some things are going on that are better there. Where do you see Omicron heading? What is your sense of the modeling? What are you seeing around the country in different regions?
So I think what we're seeing with Omicron, first of all, nowhere is in great shape. We do know that Omicron has rolled out or has impacted the population and the case trends differently in different parts of the country. We tend to, again, see it on the coast first, and we see it move into the Midwest. So Region 7, where I cover, Kansas, Missouri, Iowa, Nebraska, we are still on that very, very steep trajectory. And based on data that we've seen around the world, we anticipate that it will be a sharp decline. What we don't know is when. And we also know that there are still a lot of pockets of unvaccinated or under-vaccinated people. A lot of people haven't started their vaccine series, and a lot of people haven't gotten their booster yet. So those kind of things impact how long Omicron will hang around and how quick we'll see decline.
Yeah, it does. Now, there's a question we wanted to ask you a little bit about the Midwest and South, but can I show the heat map for just a second, folks? This is it from the Times, and you look around this heat map, we've shown it a lot of times. This is really a difficult map to see right now. I've never seen the country all be so purple at the same time, and if you look at Kansas and Missouri, it looks really, that's difficult. Then you look at the Southeast, you look down at Georgia, which I think is Region 7, and things don't look great down there. We know they don't look great in the Northeast, so man, this is a tough map, Dr. Satterwhite.
It is a tough map. So definitely, Region 4, which is where Georgia is. I have a colleague down there. It looks kind of maroon. And again, this is something that we're seeing everywhere. We knew it was coming in the very short term. Dr. Seitz, we were talking a little bit, and I know Dr. Hawkinson, we've talked about it too. Even when we know when the virus can change quickly and it can throw things at us that even though we try to prepare, hits us pretty hard, and that's where we are right now.
Yeah, and it has really gone rapidly across a lot of areas. So do you have a sense of modeling about, you said maybe the end of this month, or is it the end of February? Any ideas?
I hesitate to go too far. In my head, I'm thinking it's going to be a rough couple weeks. And then we know, though, that ICU admissions is roughly 14 days behind an infection, and death is about 21 days. So even though we may see a rapid decline in cases even in the next few weeks, there will be a lag in hospitalizations and ultimately in those very severe outcomes, including death, that we really want to prevent by getting people, preventing infection in the first place. And if we can't do that, then trying to treat people with the tools that we do have, even though they're in limited supply.
Yeah, this is going to be a bumpy ride, I think.
It's going to be a bumpy ride.
And it's a bumpy ride up in the ICU, Dr. Satterwhite. The other Dr. Satterwhite, so to speak. This is great because when I'm at home, it's one of us is the other Dr. Stein. It's usually me. I'm the other one. So you're the other one this time. So men of the world, unite here. But how are things up at the ICU?
The ICU is difficult right now. I mean, it's hard to hear. It's important to hear all the updates from the CMOs across the state and the region. That's what we're experiencing here at KU. The numbers that everybody is describing, the really severity of the critical illness. And one thing that's different to say is it's harder to get into an ICU these days than it was 2 years ago. So you've always been sick to get in an ICU, but you're another level of sick to be in the ICU right now because we're trying to extend out what we can do in our acute care, what we're trying to do at home, what we're trying to do in the clinics, all of that. But I think, as it has been stated from others, the thing that I think is most palpable right now is the people responding in the ICUs, our nurses, our physicians, our nurse practitioners, have tried through various times over this pandemic to kind of ramp up and respond to increasing demands. And that gets harder to do each time. And this time it's really been impacted and compounded because so many of our colleagues are out sick. Their families can be out sick, they're out sick, there are fewer of us, and signing up to come in to bring your heart to work and take care of people is just that much more difficult each time.
Yeah, it is a challenging time, isn't it?
Can I add
Please.
something about that? Because one thing that I see in my job, I do public health across the region, and our healthcare systems, as represented by the chief medical officers on this call, are a critical part to that system. But that system extends beyond the healthcare system, and the staffing shortages that we're hearing about on this call are happening in places like residential facilities that may support a child welfare system, correctional facilities, all of these social support services that are really important. They're seeing the staff absences too. So it's a systemic community-wide issue. And our social structure and our public health structure and our medical structure are all so closely linked that this is impacting all of society.
It is, and we also see in the nursing homes, so there's a huge rate of absenteeism. Right. Patients are backing up. You can't get people into the nursing homes, and there's a wildfire of COVID in nursing homes. So I'm a little concerned about what happens to the ICU after that. Jess, we've got a lot of questions out there, I suspect. Let's first see if there's any reporter questions on the line.
Hi, guys. It's Taylor at 41. Good morning.
Good morning, Taylor.
So I have a couple of questions, if you'll allow me. One, if I
Please.
could get you guys just to comment on urgent cares as well, because obviously you're all representing major hospitals, but a lot of people are reaching out to urgent cares. Can you speak at all to what's going on and what people should be doing as far as urgent cares and the difficulty there in getting in? Two is as far as the hospital goes, is there any effect right now on the ability to accept patients that are coming in from ambulances? Are you having to divert patients to other places because of that would normally be coming in, not necessarily even COVID related, because of ambulances? Are hospitals having to divert to one another right now because of that? And then I've got another follow-up that's a little bit more complicated after you answer those two.
You bet. We'll take them on. Let's start. Kim, you guys have a large network of urgent care. How is COVID affecting the urgent care network for HCA?
Sure, I'm glad you asked the question. The urgent cares are equally affected. As Dr. Satterwhite mentioned, this is a systemic problem in our community. It's not just hospital-based. And we are seeing a number of employees out sick in the urgent cares, just as we are in the hospitals. In addition to that, they are overloaded with sick patients, as well as patients seeking testing. So we've had a lot of backlog in our all of our urgent cares, just as we are seeing in emergency rooms. So it is completely connected.
And Advent's Shawnee Mission, Dr. Hayes, how's your urgent care network? Oh, you better unmute. Don't forget to unmute.
Thank you. Exactly like Kim said, we are overwhelmingly overwhelmed in the urgent cares. Multiple factors, employees out, having to test and isolate if they're positive, overwhelming. I know one day last week they had one urgent care that did 70 tests in one day for COVID because of limited capacity in the community for testing. A lot of people who are maybe not sick but need to know COVID results were going to the urgent care, just feeling completely overwhelmed in those urgent care settings.
Yeah, this is tough. So, Taylor, your second question, I think, had to do with how are we handling ambulances? So let's first turn to Dr. Raghu Adiga up in Liberty, because you guys have struggled at times with all the influx coming from the northern counties in Missouri.
Yeah, it's a hit or miss. I mean, obviously, we try to keep it open as much as possible. But just like all other hospitals, we have to go on high volume at times when we are just, we just have no beds. But what happens is vast majority of the hospitals are in the same situation when we are in that situation. So when that happens, we get forced open. So all hospitals get forced open. So you can't go on high volume. That means, the ambulances will arrive no matter what. So you just have to be prepared. That's the situation at most hospitals, I believe.
And Dr. Antonios in Wichita, and you keep your pulse kind of on the state as well. Talk to us both about what's going on in Wichita. What do you see throughout Kansas?
It's the same scenario. It's the same story everywhere. We hear from our partner hospitals that are all across the state, especially in the western part of the state. They're struggling to be able to do any kind of transfers. I think we heard about that loud and clear last week. When it comes to the community itself, we try to keep all our EMS partners aware of what our status is, but like everybody else mentioned, what eventually happens is that EMS, when they don't have a place to go, obviously they can't, a lot of times they can't avoid just not bringing a patient into the hospital, so they end up bringing them, and we do everything we can to deal with it. And despite the fact that, like it's been mentioned, our emergency rooms are very busy with a significant number of patients that are and increasing as well. So I guess in short, Dr. Seitz is kind of we do the best we can and try to keep everybody apprised of our situation on a daily basis.
I think here's our story that normally we try to accept 65 to 70% of patients coming to our hospital. We believe that's our role as a coronary referral center for the region, for Kansas, wherever. Today we're running about 17 or 18%, and that's not a number we like. We need to get those folks here because those are patients in smaller hospitals or places that need our help. And I think all of us on this call would echo the same thing. We want to take those people, but we don't have a place to put them, and we don't have the staff to take care of them. We've tried to divert a lot of staff away. I got a note from Chris Reuter was on a program on Monday with us, and we've been shifting clinical staff and non-direct roles back to assist with direct patient care. We've taken non-clinical employees, people like hospital administrators like myself and Chris Reuter, to go do things like patient transport, cleaning, meal tray delivery, stocking. These are things that we don't have anybody to do, so we're deploying anyone over to do that. We were getting students from the School of Medicine, the School of Nelson, and the School of Nursing to help assist with care functions. We're using retired healthcare personnel. We're suspending other types of work for people to do that other projects we may have focused on, strategic planning, let's say. All right, we can't do as much of that right now. We're pulling those people back, and then everyone starts to go, well, what about my planning? I want to go do, well, no, right now the only thing we're talking about is COVID. So we're doing things that we would not, this is an all hands on deck approach. And the one thing that's not written on this, and I'm going to turn to Dr. Satterwhite for a comment, we know that COVID has a high mortality rate. But when we can't get people taken care of, mortality rates for all diseases rise. Heart attack, stroke, cancer. It's not just COVID patients who are affected by this. Catherine, I think it's everybody.
It's absolutely everybody, and I think that's really illustrated by the holdup in the ER too. Every person on this call talked about people waiting in beds in the emergency department, and those aren't just COVID patients. Those are all sorts of people coming in. And, frankly, we know that we've been talking a lot about, don't delay your preventive care, take care of yourself. And people are trying to do that, but we also are still in a place where people might not be doing the things that they might have done to keep themselves healthy. So yeah, strokes, heart attacks, falls, normal injuries. Everybody is impacted by this. And I do have another comment I wanted to build on. So the idea of, so you said all hands on deck, we've heard that a couple times. We are at the federal level seeing an increase in the number of healthcare systems who are seeking federal staffing assistance. And it's an interesting space for us to be in. So we were lucky in that we were able to provide a DMAT team to the Kansas City area.
Tell what DMAT is.
DMAT is Disaster Medical Assistance Team. So that is a team of healthcare professionals who come in and exactly try to augment, but hopefully at least try to fill the holes that we know we're experiencing. But we have a number of assessments that we're doing across the region because we've had similar requests. We're not going to be able to fill them all. And we're partnering with the Department of Defense to try to bring these medical professionals to the places we need most. So I just am saying that to illustrate, again, we have some resources, but everybody is in such a bad place right now.
Yeah, these are difficult times, and again, I can't underestimate enough, Taylor, the impact on not just COVID patients with the emergency problems. All patients who seek care are going to experience delays because of how emergency rooms are backed up. Remember, last week in the CMO conference, we talked about the Mission Control app. The deaths in emergency rooms waiting on transfer were 5 times higher in December than ever before, than baseline because of this delay. So things are hard across the board. Taylor, I'm going to follow up with you.
Yes, sir. I had one more question about testing. I myself experienced some of the frustration with this because I was fighting the flu over the weekend and had to go and find a test. Thankfully, I was able to find one a day after that was negative. But I want to ask you guys, what is the largest threat to the overall situation right now because of testing? Is it because people may be positive, they're not able to get a test and not act as if they're positive? What is the biggest problem with people not having access to quick testing and results right now?
Yeah, I think the biggest problem, Hawkeye, is that people won't know if they're positive, and as a result, they may act like they're not positive, and that's a concern. Yeah. And the second thing I want to get into in just a minute is how accurate are the antigen tests at home in the Omicron era. So let's first lead off with Hawkeye, though. I think the problem is the illusion that I'm okay.
Mm-hmm. Yeah, we are trying to explain large concepts, and we've been trying to do this, just large concepts about the protection of the vaccines, especially against hospitalization. Here's another large concept, abundance of caution. And so I think you have to go about this with an abundance of caution. And we know the disease is prevalent throughout the community right now. If you have symptoms and you can't get a test, you need to go forth with an abundance of caution. And that means really to act as if you do have it. Do that isolation. Now we know for the general public that isolation guidance has been reduced. So, it is much less than it used to be, but I think moving forward, it has to be with the concept of using that abundance of caution.
Dr. Adiga, you're an infectious disease doctor as well. When people call you and say, I can't find a test, what do you tell them to do?
Exactly was what Hawkeye said. I mean, obviously, each situation is different. We first assess whether it is for their own health. If they are high risk and they're potentially going to get sicker and having to be hospitalized, it's a different matter. Then we try our best to try to find the test somewhere. But if it is the question of trying to isolate yourself and prevent spreading it to others, you just follow what Dr. Hawkeye just said. You have to isolate yourself. You have to remember, though, the current guidelines of 5 days of isolation. It only works for about 70% of people. So there is still another 30% of people who could still be positive and spreading it when you get to day number 6. So that's the important part of the recommendation there is for being really careful for the next 5 days, wearing the mask and avoiding crowd. Even if you are an essential person, you need to be somewhere. then you still have to, exercise caution.
And Catherine, we know there's not immediate relief yet on the testing side. We're not going to have enough tests for a while.
We have there are a number of plans in place to try to continue to increase test availability, and test availability has increased quite substantially over the past 2 years, but we know we need more. There are a number of programs that are where we're injecting point of care tests. We're trying to support PCR tests in a variety of ways. In particular, we're trying to make sure that schools have access to the tests they need. There are a couple federal programs that schools can partner with to test students on site. Again, using a variety of approaches. We're trying to, like we've talked about, all hands on deck with people, or all tests on deck, all kinds of tests to meet whatever need they best align with. So it's not perfect. We did have an announcement in the past few days from the federal government that private insurance companies will now be required to cover the cost of over-the-counter point-of-care tests. The logistics on that are certainly still being worked out, but that's big. Medicaid had previously covered them, but we're trying to do a variety of things to increase access and reduce barriers to getting tests once we have that supply that we need.
I think the other thing just to point out is that home testing is not as sensitive in the age of Omicron as a nasal PCR, and there aren't enough nasal PCRs, so tests available. So at the end of the day, I'm reading, and I'm curious to see if anyone has any better data on the call here, but only the sensitivity rate can be as low as 30% for home testing. Maybe it's 70-80%. It is not 95%. Thoughts about that?
So actually, there are over 400 tests for COVID-19 that have an emergency use authorization from FDA.
That's a lot.
It's a lot, and each one of those tests is slightly different. So I think that's probably, for me, the takeaway is not every test is perfect. Practicing an abundance of caution, staying home when you're sick and wearing your mask are more important.
Yeah. Oh, wait, the rules of infection prevention and control, they still work. They still travel with you, and they will still keep you safe.
There you go.
Even in the age of Omicron.
Well, as we're talking about these testing, one of the ones you've educated from the beginning is stay home if you're sick, and whether or not your test is positive or negative, you still need to stay home if you're sick. You may have COVID and the test has not been sensitive enough to pick it up, or you may have another illness or virus that could also be spread. So even if you're testing and it's negative and you're feeling sick, you need to stay home.
Other questions? Jess, are there any community questions out there today? I'm just guessing that the answer to that will be yes.
Yes, you are correct. Many good questions. So I'm going to start with Sarah. She wants to know, with each medical system as full as everyone is saying they are, how are they handling the mental health facilities, that portion of the health systems? How are they handling those COVID patients, and what's that look like?
Yeah, I'll tell you, and Dr. Hayes, you talked about this the other day on the CMO call, the impact on mental health. And let's hear from you and Dr. Megow today. But starting with you, Lisa, what's the sense that you have about the impact of mental health for your staff and for COVID patients?
Yeah, I would say for our staff, they're on the brink. Every day when I round in the intensive care unit and check on the staff, people are in tears. They're struggling to get the community to understand how dire the situation is in the hospital, and the workload that they're taking on, as well as, balancing, they're the eyes and ears and the family almost for those patients that can't have visitors because of being COVID. So they're feeling the emotional burden, definitely. And we're continuing to do team member well-being calls. We have a psychologist on staff for the physicians. We have a social worker on staff for the team members as well. We're trying the best we can to help keep everyone mentally healthy as well as physically healthy so that they can be caring for those patients. And, in behavioral health, those patients, they just keep coming. We're seeing, honestly, a high amount of individuals needing hospitalization for detox from alcohol and other substances. I'm hearing on other CMO calls of a high volume of drug overdoses, and those individuals usually need to be monitored in the intensive care unit as well. And so that is a burden on the system as well. Many of us can't take COVID positive patients into our behavioral health closed units. So they're having to be taken care of on a medical surgical floor, and not always getting the same access to the group therapy that they need. It just keeps going. It's a burden.
Dr. Megow, HCA.
Yes, I would echo a lot of what Dr. Hayes has just said. We are extremely concerned about our frontline caregivers, physicians and nurses and therapists alike. They are all working extremely hard, but they suffer as well. It's an emotional toil, it's a physical toil, and it's been going on for long enough that we're seeing the effects of that. They're not giving up, but they're having a harder time, and we certainly want to provide whatever kind of support we can, and we do that. I would say, as far as the patients who have behavioral health diagnosis, that is a challenge as well. That was a challenge before COVID, as we all know. And it's gotten worse. We've seen a higher incidence of behavioral health diagnosis. And for those patients who are also COVID positive, unfortunately, many of them are held in our emergency departments for extended periods of time, awaiting placement, because a COVID positive behavioral health patient is much more difficult to place in the appropriate setting than a negative patient. So we're seeing that across the market in all of our facilities and our emergency rooms. So it is a big concern.
Jess.
Dr. Seitz, Michael is confused regarding the ventilator situation. He was checking out the Mid-American Regional Council website, and in Johnson County, it shows that there's 119 available ventilators. I mean, that would make the public think there's nothing to worry about. There are plenty of supplies. Help us understand what that website is telling us about ventilator supplies.
Yeah, and I think Dr. Lewis Satterwhite can help comment, but I suspect the question is you got to have the right kind of ventilator for a COVID patient.
Yeah, I can't speak specifically to the numbers on the MARC website, but certainly there are the ventilators that are usually deployed in a hospital that the staff are familiar with and able to adjust and manipulate in a facile way, with very specific abilities to support with very high levels of pressure, very high levels of oxygen. And oftentimes what we have for disaster relief are very simple machines that can provide very basic levels of support. And what a lot of hospitals are doing, and we have contingency plans for, are then how to not only figure out how to get the right patients in the right places, but then the right ventilators in the right places. And then could we use a ventilator that we're not very used to, that has very limited capabilities for surgery support, or a person that's sick with something other than their lungs, and it just adds to a stress on the system and complexity. And not all of them are created equally, and not all of them are able to support the very, very sick people with bad lung injury.
Dr. Seitz, I think Dr. Adiga needs to scooch, so we just wanted to thank him for being on with us today and see if he had any final thoughts for us.
Dr. Adiga.
Thank you for having me. I'm sorry I had to get on to another meeting. I think the key message all of us are telling people is that we are really at the highest level of crisis that we've seen in the healthcare system for a long time. And this is going to be here at least this week and next, and people really have to be careful on what they're doing outside, and try to help our really struggling healthcare workers. They're putting their heart and soul into this to keep people healthy, and the physical and emotional exhaustion that's on them is just unimaginable. So be nice. That's all I have to say.
Thank you, Dr. Adiga. And I know Dr. Hayes has to go as well. Just to say, I want to thank everyone who joined this call. All these CMOs kind of did. We did this last night because after the results of the CMO call, things were a little rough. We heard, and then we heard more news last night about how bad things were. We want to make sure we got that out to the community about how dire it is. And so we appreciate all these guys at the last minute pivoting. So, Dr. Hayes, final thoughts from you?
Yeah, I have a couple of thoughts. I would echo what Dr. Adiga said as far as just extend grace wherever you go. Extend it to your healthcare workers, your teachers, your bus drivers. Everyone's doing the best they can. People are doing things that they're maybe not used to, and everyone's stepping up to be a team player. And we need to do our part as well as being a team player, making sure that we're wearing masks in the community, making sure that we're getting vaccinated, staying home when we're sick, because if we continue to overwhelm the healthcare system as we're doing, you may not have COVID, you may not come to the hospital with COVID, but you may not be able to get timely care for your non-COVID illness. And just extend grace. That's my parting words.
Yeah, those are great words. Jess.
Dr. Seitz, I know our entire panel is busy and has to get going here pretty soon. A couple more questions, though. Emily wants to know, are any of the health systems canceling surgeries within the next week or two?
Oh, gosh, we've been canceling left and right or deferring. Dr. Antonios, let's talk a little bit about the situation in Wichita.
Yeah, we've asked our surgeons to be very cognizant of our situation, and they are. They see it actually on the ground, and they've been trying to prioritize certain surgeries. I mentioned on the call last time, as a tertiary care center, we don't have a lot of cases that can be easily rescheduled just because of the nature of the type of diseases that we take care of. And so we also don't want to impact patients' lives. But yes, we have been asking our surgeons to assist us in this. I did want to comment, if you don't mind, Dr. Seitz, and I do
Please.
have to sign off after this comment on a couple of things that were mentioned that I think are very important when it was a conversation about wellness and mental health of the workers. I still think all our staff are heroes, and they will forever be heroes. From my standpoint, there is a lot of pressure on them, and kindness is probably the easiest thing that people could today extend. It costs nothing, but to be kind and show grace to our healthcare workers who are, despite all the adversities, are showing up to work and doing a very tough job. And the last thing is that I actually took note here of something that was said on this call, and I think it could be a takeaway from this call, is abundance of caution. It's abundance of caution for people who, as mentioned, could be exposed or maybe have a disease, and how they should behave and wear a mask and be careful around others. But it's also abundance of caution for everybody else, because as you heard, there's been an impact on the non-COVID situation. So people who are at risk of other injuries, they may or may not actually get impacted in their care, even if it's not COVID-19. So abundance of caution in the community is probably the appropriate advice that I would give. And with that, I would sign off. Thank you, everybody.
Dr.
On the
Antonios,
panel.
thank you. And thanks for the great work you're doing in Wichita and throughout Kansas. So appreciated. All right, Jess. Kim, still with us? All right.
So Mary has a question for Dr. Satterwhite. Does Medicare cover over-the-counter at-home tests?
You covered that just a little while ago.
Medicare,
it's coming.
Medicare is a little bit tricky. That is not currently quite as clear as Medicaid and private insurers. So I will have to defer that. I think we're going to learn more about that hopefully soon.
A lot of questions today. The same as yesterday, we got a lot about masking. And
yes, you should wear a mask.
Yes, but now people are going to the CDC website and trying to figure out what the right ones are to wear. Should they be wearing cloth masks? Should they be wearing N95s? Where should they get them? We can answer several people's questions this morning. Can you just go over that again?
Yeah, let's try
We're asking
that.
people to wear masks, so if they're asking, I want to make sure they're wearing them right.
Yeah. So let's start with that. Kim, let's start with you at HCA. What are y'all doing with your staff now with masking?
Well, we've had everyone in the hospitals and all of our healthcare facilities have been masked, for the last 2 years if they're in the buildings. But currently, we do believe that a well-fitting mask is important. So masks that are loose around the sides of the cheeks or around the nose are not as effective as one that is more closely adhered to the skin in all of that area. We do think a multi-layer cloth mask is more effective than a single layer like a bandana. And for our healthcare workers who are working with patients, either a KN95 or a fit-tested N95 mask is really the recommended mask. We do have some level 3 or surgical masks in use in certain areas of the hospital, and as well as eye protection in all patient care areas.
And Hawkeye, I know we're watching closely this controversy about what's the right mask in the Omicron era.
Getting a mask on is the right mask. So we have said we know early data suggested that there were differences in filtration and the ability to block from a 2 to 3 layer cloth mask to a surgical mask and up to a N95 mask. So we knew about that. The CDC guidance, though, has remained pretty stable since early in the pandemic, saying that any of those things will work. They did update it once there was a journal article about double masking, and again, that journal article was specifically about a cloth mask over a surgical mask. But their main points continue to be, just as we heard from our guest, about the snug fit and making sure that it fits correctly. So, we will be waiting for that. They are looking at that, but we have an abundance of data now showing that just wearing a mask, even if no other people are wearing a mask, even if it's a surgical mask, will continue to protect you. So I think that's important to know, and certainly we will be updating as the guidance from the CDC changes.
All right, Dr. Catherine Satterwhite.
Yeah,
Is the CDC going to change their guidance? Are they pivoting?
I do not know in my crystal ball, but I do think that there were a couple of points that were just mentioned that are really worth highlighting. Well-fitting. That means close to your face. You can tighten, if you're using disposable masks, you can tighten those loops around your ears. CDC does recommend that there's a nose bridge, so you can fit it on top of your nose. That also helps with glasses fogging for those of you who might wear glasses. Double masking. The important thing, and I have noticed in the community that I'm seeing more masks, voluntary masks, than I have in the past, which is awesome. I think people are trying to pay attention to risk and titrate their behavior as they're paying attention to what's going around them. However, I do still see a lot of incorrect mask usage, even given what we've talked about. A lot below the nose, a lot of gappy masks, and also a lot of if you are eating or drinking, that doesn't mean hang that mask on your ear the entire time you're eating and drinking. First of all, I think eating and drinking is a risk, but if you are doing that, you really you need to put that mask on every time you are not actively chewing, or you're not biting or drinking. So I don't know what they're going to do. I think well-fitting, consistent use is where we need to be.
Yep. Well, Jess, let's have one more question, then we need to probably wrap up.
Okay, Isaac wants to know any regions where Omicron is approaching a peak or beginning to flatten.
Oh, that's a great question. Okay, so I'm just going to say I did spend a lot of time looking at maps for different states. And New York City started to report yesterday that they thought they were seeing some flattening. If you look at the state-by-state map, there's a couple of states in the Northeast. Delaware had a little bit of a flattening. Is this good news, or is this too early to tell, Dr. Satterwhite?
I think it's maybe good news. I think that we have to wait a couple days. It's certainly exciting. The possibility is exciting, but I don't think we know quite enough now to know if we are really peaking out, or even what that, if we're going to see that rapid trajectory that we hope for based on some other global data. And I will say the other thing to remember is even on the backside, even if we see the curve slowing in some places, doesn't mean that nobody's getting infected anymore. It might mean that not as many people are, but we still are going to have people getting infected on that entire backside, which is going to impact our whole healthcare system.
Yeah, and I think the other thing, there's some data coming out of California yesterday saying that, and look at it as a Kaiser database, interestingly. So not sure that the patients necessarily represent all the other patients, because Kaiser has a bit of a select population, but that hospitalizations were about 50% down, and ICU ventilators were down compared to the Delta and other variants. The problem is, again, select population. We'll see, because we're not feeling that here yet so far. We're still seeing a lot of sickness and a lot of death.
We're still seeing a lot of sickness and a lot of death, and there's been a lot of talk about decoupling infections and hospitalizations and deaths, and that would be wonderful. But even if it decouples to some degree, it's not a dissociation or a complete divorce from it. When your cases go up exponentially, then you're still having more hospitalizations, more deaths, and we're living that right now.
Dr. Kim Megow, final thoughts for today.
Thanks again for having me this morning, Steve. I would echo what I've heard my colleagues say and ask those who are watching and listening to please exercise an abundance of caution, stay home if you're sick, use good infection control measures, and be kind to each other.
Yeah, I think that's right. Kindness amongst the viral blizzard. Dr. Catherine Satterwhite.
I have two thoughts. First, that we've talked a lot about hospitalization and a little bit about death, but remember that there are other outcomes of COVID-19, like long COVID, like persistence of symptoms, and those matter too. So we do need to be doing everything we can to prevent infection still, prevent ourselves from getting infected, and if we have COVID-19, prevent others. So, however, having said that, I do want to end on a bright note. One of the most exciting things that happened last week was that boosters were recommended for 12 to 17-year-olds. And that's huge because we know that boosters make a big difference, not just with Omicron, but also with Delta and maybe with whatever might be coming our way. So if you have a child from 12 to 17 and you have an opportunity to go get boosted, please do so. It's great news. It's an important tool. And I'm really happy that we've got that now.
Yeah, I like that as well. Dr. Satterwhite.
I think it's amazing how the themes come out. I would also say thank you for letting me be here, and would like to finish on the be kind to each other. As I was trying to think about being on the show this morning and polled some of my colleagues about how they're feeling and what's going on and what they're experiencing, a lot of them are feeling a lack of that. They don't seem to be seen right now. And so if you can, we mentioned those performing all kinds of public services, those working in nursing home facilities and schools and wherever, people that are out there trying to help make daily life better and easier. Be kind and say thank you.
Hawk?
Yeah, I'd like to piggyback on Dr. Catherine Satterwhite's points and kind of meld her 2 points about other outcomes other than severe hospitalization and death. Along with the pediatrics, we know that the vaccines can help prevent long COVID as well. We also know in a very small study that they can help prevent those multi-system inflammatory disorder in children as well. So if you have a child that is 12 and up and who is meets that criteria for getting that booster, that additional dose, please go get it. It can save more than just them going to the hospital. Otherwise, I'm just going to agree with the thoughtful comments from all of our guests. So.
Jess, here's my final thought. In a world of hurt, it's best to be at our best. You know, we try to be at our best every day for everybody and every single patient that's here. Our boss, Bob Page, says there are no more bad days when you're an employee here. So we're trying to be at our very best every single moment of every single day. And we try to make sure our patients get our best. All of the CMOs would say that today. All of our hospitals would say we try to be at our best. We need everyone to try and be at their best. And there's some folks that can maybe take some avoidance maneuvers, but some folks like teachers, police. By the way, COVID has become the highest killer of police officers in the United States now. The fire department, the first responders, EMS, you know, your supply chain industry, the food service workers. I mean, these folks all have to be there, or we can't get any of the services we need to keep society going. We ask that everybody be at their best to try and help and protect, take care of each other. There is a world of hurt. We can do better. Put on your mask. Put on your mask. Try and take care of each other. And remember that love, at the end of the day, is still more powerful than anger. We're all angry with COVID, but that doesn't make grace or love any less important. Actually, it's the opposite. It makes them more important. And just, I don't think there's anything more important than taking care of each other.
I could not agree more. Dr. Seitz, thank you so much. Okay, so we have a really great show tomorrow. Remember this man, we told you about his story. His name is Anil Garmalkar. He shared his story of survival from COVID-19 back in 2020. We are going to get an update from him. He's going to join our show live. This COVID long hauler now has a permanent reminder of what he went through, and it's now something he cannot live without. Dr. Keith Sale is also going to join us to update the numbers of long haulers that we're seeing inside our COVID clinic, what you need to know. We'll do that tomorrow starting at 8. Have a great day.
With Dr. Steitz podcasts. Now everywhere podcasts are available.